So what we were interested in finding out, a few years ago we had done some studies showing that if we take people with type 2 diabetes and treat them with CPAP and make sure they wear the CPAP the entire duration of sleep, their blood glucose levels can improve. However, that study that we did a few years ago was in a small set of patients with type 2 diabetes. Naturally, the question that comes up is, when you look at a larger sample size, do you still see that effect? So what we aim to do in the current study was piggyback on another clinical trial that was funded by the National Institutes of Health here in the United States. And the parent study was designed to test treatment interventions, treatment medications for type 2 diabetes as a prevention for people with prediabetes. So the study was designed to enroll people with prediabetes, give them medications, and compare them to placebo to see if treatment with medications can slow the progression of prediabetes to diabetes. Obviously, we're talking about type 2 diabetes. And the question that we ask is, at the time of enrollment in this study, let's assess these individuals' sleep. And what we set out to do was to examine them for obstructive sleep apnea. So all individuals underwent a sleep study in the laboratory for one night. And they also wore one of these accelerometers on the wrist, similar to a fancy Fitbit device, for 1 week, so we can assess their sleep-wake patterns. And our hypothesis was individuals who have obstructive sleep apnea that is untreated, or people who habitually sleep less than what they should, will have worse blood sugar levels, and their pancreatic beta cell that produces insulin will be more impacted adversely by abnormal sleep. That was our hypothesis. So what we did in this study is we were able to obtain all these variables: sleep duration, sleep quality, presence of sleep apnea in 221 adults. And what we found is, again, not surprisingly, 89% of the patients or the participants had sleep apnea. The average age of the cohort was around in the mid-50s. Obviously, they were overweight and obese. And we had good representation of women in the study. We had around 43-44% women. So 89% was quite high. But again, not surprisingly, because other people have seen this as well. What was shocking was 40% had severe sleep apnea. Another 20-something%, close to 30%, had moderate sleep apnea. So if you add up those two, you're close to 70% of these individuals having moderate to severe sleep apnea. To our surprise, however, when we looked at the various categories of sleep apnea severity or various durations of habitual sleep, we were not able to see any associations between severity of sleep apnea and very robust measures of the body's ability to produce insulin, because that was the ultimate question. And I think that what our study adds to the literature is most of the studies have looked at rough estimates of blood glucose by simply doing fasting blood sugar levels, or the marker of diabetes that people use in clinical practice called hemoglobin A1C, that gives you an average of what your blood sugar has been for the last 2-3 months. In this study, we really took it a step further. All these individuals underwent very labor-intensive procedures in the laboratory, and these procedures are not done in clinical practice, but these are research procedures that are really designed to assess the body's ability to produce insulin when it needs to. We call them hyperglycemic clamps. And it measures also how sensitive is your body to the insulin you produce. So we had really a relatively large sample size undergoing these very robust measures of beta cell function and insulin resistance or insulin sensitivity. That's, I think, what's unique about our study. But again, in contrast, what we did not find is we could not confirm our hypothesis. In other words, again, our hypothesis was people with severe obstructive sleep apnea compared to no sleep apnea or mild sleep apnea will have less ability to produce insulin, or they will be more insulin resistant. But our data didn't confirm that. So, and that's in some contrast with some other studies that have been published. And one possibility is that the way we measured insulin sensitivity and insulin secretion may have been much more robust than what other studies have measured, techniques that they've used. But I think the challenge now is for other investigators to try to replicate our data to see if in other populations, more diverse populations, whether they have the same findings. And in my view, the ultimate question remains whether treatment of sleep apnea, and when I say treatment, I mean effective treatment, will lead to improvement of insulin secretion and insulin sensitivity, so that people who don't have diabetes yet, but they're at risk, in other words, people with prediabetes, you would lower their chance of getting diabetes vis-a-vis treating their sleep apnea effectively. But I think we will need a few more years of investigation to be able to prove that point. At this point, our data suggests that there's not a strong association between severity of sleep apnea and the body's ability to produce insulin, or the body's resistance to insulin, so to speak. So it's important not to draw draconian recommendations based on our study. We have to understand that our study has significant and important limitations. One being that it was not what we call a randomized controlled trial. It was mostly an observational study. The data collection was performed under the auspices of the parent study, which was a randomized controlled trial. However, all the data on sleep that we collected on these individuals was before they started any form of therapy for diabetes or prediabetes. So at the end of the day, even though the parent study was a randomized controlled trial, the RISE study, which stands for Restoring Insulin Secretion study, our analysis of sleep was done at baseline only. And what we find is that, as I said earlier, we didn't find any important associations between severity of sleep apnea or sleep duration, for that matter, and worsening blood glucose control or body's ability to produce insulin. But I think we all have to be cautious about this, because the ultimate evidence would be from studies that show whether treatment of obstructive sleep apnea or interventions that improve sleep quality, be it extending your sleep or trying to improve your sleep hygiene, whether those interventions ultimately lead, compared to no intervention or a placebo intervention, whether those clinical trials will lead any positive effect. Those are the data we're going to need, and I think that's where the field is moving, to perform those clinical trials. But again, any of these clinical trials are expensive, they're labor intensive, requires funding, requires volunteers to donate their time and their body to science to undergo these experiments as research subjects, and it's going to take time. So I think the jury is still out as to whether treatment of obstructive sleep apnea will lead to either halting the progression of diabetes or actually improving the outcomes of diabetes once diabetes is established. So I think that's where the field is moving, and hopefully in the next few years we'll have a few more answers on that. In regards to the next steps for the current research that we've performed, right now, again, as you know, we're just presenting this in an abstract form here at the American Thoracic Society International meeting, but we still haven't, delved into all the details of the data. So this is roughly the first pass at the data. We have to try to understand whether there's any differences. For example, our cohort was quite diverse. We had, a good representation of Black Americans or African Americans, Latinos. So I think it will be important to understand whether there's any racial ethnic differences, whether there's any sex differences in terms of men versus women, and whether we can understand if there's any particular type of patient or participant who would be more favorable to enroll for future studies. Unfortunately, one of the problems we have is we treat all human beings the same, but it's possible that not all people who have diabetes or pre-diabetes are the same. The question is whether we can identify ahead of the game who are the people who may benefit from treatment of sleep apnea and identify them and then test the hypothesis in them as opposed to just enrolling all comers. But again, that's easier said than done. And I think, hopefully, with informatics and big data, maybe we'll be in genomics, maybe we'll be able to identify those patients to enroll them in the appropriate clinical trial and not enroll everybody. So I think that's the wave of the future.